Welcome to today's webinar, hosted by the National Association of Emergency Medical Technicians and the National Pre-Hospital Pediatric Readiness Project, and sponsored by FirstNet, built with AT&T. I'm delighted to introduce you to today's presenters, Dr. Kathleen Adelgaze and Dr. Manish Shah. Dr. Adelgaze is a professor of pediatrics and emergency medicine at the University of Colorado School of Medicine and a pediatric emergency medicine physician at Children's Hospital Colorado in Aurora, Colorado. Dr. Shah is a professor of emergency medicine and pediatrics at Stanford University School of Medicine, a principal investigator of the Pediatric Dose Optimization for Seizures in EMS, or PEDIDOSE study, and a principal investigator for the Charlotte, Houston, and Milwaukee Pre-Hospital CHAMP research node of the Pediatric Emergency Care Applied Research Network, or PECARN. For more background on our speakers, please view the speaker bios on your Resources tab. Welcome, Drs. Adelgaze and Shah. I'll turn the program over to you now.
Thank you for having us.
Yes, thank you so much. So the work that we will be talking about today is from the National Pre-Hospital Pediatric Readiness Project, which is funded through the Health Resources and Services Administration. It's an Emergency Medical Services for Children program. And our objectives for our presentation today are to share the findings of this first ever National Pre-Hospital Pediatric Readiness Project assessment that was done nationwide in the United States. I see that we have an international audience, so I'm excited to see the reach of the interest in this topic. Second is understand how statewide pre-hospital pediatric readiness programs, and specifically the role of a pediatric emergency care coordinator, can be used to support this concept of pediatric readiness, and then to share some specific resources with you. And so first, before we get into the results, we wanted to talk about just the inception of the PPRP. I'm going to refer to it as the PPRP from now onwards. The PPRP started as an initiative of the Emergency Medical Services for Children program. And the EMSC program was created in 1984 through bipartisan support from Congress, with the mission of reducing morbidity and mortality for children when they face a medical emergency or traumatic illness along the entire emergency care continuum, from pre-hospital into the hospital and then on beyond. And when we look at pre-hospital care, on the next slide, more than 100 million people seek emergency care in the United States annually, and 1/3 of them are children. So care starts as soon as someone notices that an emergency is occurring, and 1 out of 6 of those individuals that seek emergency care do so through the 911 emergency response system. Pediatric calls, however, only account for 10% of those calls, and that still amounts to a large number of patients. However, nearly 2 million EMS calls for children on an annual basis in the United States. And so the infrequency of pediatric calls poses a challenge and a gap in care when it comes to protocols, equipment availability, and workforce readiness. And so on this next slide, I'm going to read some quotes from EMS clinicians that really highlight why this is an issue for them. And so the first one, it makes us not forget that pediatrics is not different from adults. Volume of adults overshadows children. Improvement in both skills and knowledge. Repetition builds familiarity. The second quote, providers are more comfortable taking care of kids. They know they have the right guidelines, right equipment, and right training to do the job. And then finally, we had a 12-year-old in a very, very bad car accident. C1 and C2 were completely unattached. I think that our training on pediatrics allowed our crew to do what they needed to do. The only reason that this child was able to be resuscitated was because our crew just did not give up on him. And so these are highlights from EMS clinicians on the importance of pediatric readiness. And on the Emergency Medical Services for Children program has received even communication from other stakeholders in the community. And this email is from a parent that talked about their experience. Following a tragic accident involving an aerosol can explosion, my young child suffered facial burns and had to be intubated by rural EMS responders. Due to a lack of pediatric equipment and training, he was intubated with an adult-sized endotracheal tube. That one moment led to unnecessary time on a ventilator, scarring in his airway, a readmission after discharge, and multiple procedures. What nearly took his life wasn't the fire. It was the lack of pediatric readiness in our local EMS system. And so I think you can see from these quotes that EMS clinicians know the importance of delivering excellent care to children. And we see even from the parent perspective that there are gaps in care. And so this whole initiative started to have a national pre-hospital pediatric readiness project back when I was the chair of the American Academy of Pediatrics section on emergency medicine's EMS subcommittee. And you may recognize on this slide, Dr. Marian Gaucher-Hill. So Marian Gaucher-Hill had developed this concept of readiness in the emergency department through the National Pediatric Readiness Project, which preceded the PPRP that we're talking about today. And the results from the NPRP, that emergency department-based assessment that has been going on for over nearly 20 years now, really helped drive quality improvement for emergency department-based care for children, facilitate research on the association between pediatric readiness and patient outcomes, and address gaps in emergency department-based care. And so this NPRP that's focused on care in the hospital was done through a joint policy statement from the American Academy of Pediatrics, American College of Emergency Physicians, and the Emergency Nurses Association. And so Dr. Gaucher-Hill reached out to me when I was chairing this EMS subcommittee to say, I think we need to do something similar when it comes to pre-hospital care to ensure pediatric readiness. And so we embarked on a long journey to also start the process of creating a policy statement to address this issue. And in addition to partnering with those three organizations that I mentioned that focus on ED readiness, we also partnered with the National Association of Emergency Medical Technicians and the National Association of EMS Physicians. And that policy statement was eventually published in 2020, and that led to the creation of a checklist. And so this checklist is something that EMS agencies can use to determine their own readiness and identify some gaps in care. And then that checklist led to the creation for both the NPRP and now the PPRP, a toolkit of resources that we'll share with you, as well as this national assessment that we're going to be talking about in more depth today. And so this National Pre-Hospital Pediatric Readiness Project is truly a quality improvement effort that's aimed at ensuring high-quality pediatric pre-hospital care. And it was formed based on the tenets of what's in that policy statement that was published back in 2020. And so I wanted to share with you just the creation of some aspects of this in terms of the toolkit and the assessment, because this was very much something that involved stakeholders from multiple aspects of EMS care. So the steering committee that was formed back in 2019. And our steering committee meets on a quarterly basis and is comprised of the organizations that you see here on the slide. There's too many to name, so I won't name them all, but you can see the logos of the organizations that we really tried to ensure that all aspects of pre-hospital care and stakeholders in those aspects of care were at the table when we were developing this toolkit and this assessment. And so, as I mentioned, that policy statement was eventually published, and it was a joint publication in Annals of Emergency Medicine, the Journal of Pediatrics, and Pre-Hospital Emergency Care. And then there was an accompanying technical report that goes into more depth on what's in that policy statement and describes some of the nuances of how to implement some of the things that are recommended in the policy statement. And that was published in the Journal of Pediatrics, also in 2020. So one important function of the technical report was that it outlined pre-hospital pediatric readiness focus areas or domains. And so you'll see here on this slide, there are 8 domains that we have. It's 7 domains actually, and then you'll see in a moment how we created an 8th. But there were initially 7 domains in the policy statement, and these domains help emphasize that readiness is not just about equipment or training, it's a comprehensive approach to improving care. And so, as I mentioned, what grew out of the domains that were identified in that policy statement was a checklist and a toolkit. And so on this slide, there are QR codes that you can scan to access the checklist and download it for yourself, as well as a QR code that will route you to the Emergency Medical Services for Children Innovation and Improvement Center's website, where we have all of the resources of that toolkit housed for public use. So I'll dive deeper now into the development of the assessment. So following the development of the checklist, our steering committee developed an assessment. And while the checklist targets broad components of what's in that policy statement, the assessment reflects actionable aspects of the policy statement. And so as our assessment work group embarked on the process of creating the assessment, we designed it to be similar to the NPRP, that's emergency department based in many ways. It's online, it's open access, so that all 911 responding ground agencies that provide EMS services could assess themselves, even between scheduled assessments by the Emergency Medical Services for Children program. We designed it so that we would have a sufficient response from EMS agencies with different pediatric call volumes and response types, so that we could really define benchmarks of different types of EMS agencies, and so that EMS agencies can see data relative to similar agencies as well. And also, we wanted them to receive an immediate score after completing the assessment, along with a gap report that identified areas for improvement with a curated list of those evidence-based resources that I noted that exist in our toolkit. So from 2020 to 2021, we created the assessment questions with a plan for an electronic build in 2022, a first round of pilot testing in 2023, so that we could then use that feedback to then refine it before rolling it out in 2024. And so several members of the assessment work group wrote up the full description of how the assessment was developed, and this was published in Academic Emergency Medicine in 2024. So I'm going to provide a very high-level overview of what is in that manuscript before Dr. Adelgay shares the assessment results with you. So our first step was refining the checklist to develop a meaningful assessment. And so although everything that the steering committee included in the checklist was important and based on the policy statement, we acknowledged that not everything in the checklist could be meaningfully assessed through a survey. And so therefore we sought out the steering committee's input to refine the items on the checklist to identify what should be included on the assessment. And so using a modified Delphi process, the work group distributed the online survey to all steering committee members and requested that each member rate each checklist item on a 5-point Likert scale with respect to the 5 domains that you see here. How relevant is this item to the care of pediatric patients in the EMS setting? How discriminatory is the item to determine pediatric readiness of the EMS agency to care for the pediatric patient? How critical is this item for an agency to meet the emergency care needs of pediatric patients in the EMS setting? How feasible is it for an EMS agency to assess this item? And how easy would it be for the EMS agency to operationalize this item within their system? And so our second step was based on the evidence demonstrating how the presence of hospital-based pediatric emergency care coordinators was associated with ED readiness in the NPRP. We decided to create a separate domain for that. So we created this 8th domain that you see here listed second in the table, and that's for Pediatric Emergency Care Coordination, or PEC. And we identified these 8 domains, and similar to the structure of the NPRP, we wanted to create an assessment that could be scored on a 100-point scale. So what we did was to establish relative weights among these 8 domains, the assessment work group was asked to assign relative importance to each of these domains so that we could develop weighting for the domains themselves. We averaged the responses that they came up with, and the final weights that came out of that analysis are what's shown here. And so you'll see that education and competencies accounts for 15 points out of a 100 when it comes to the assessment, and family-centered care accounts for 10. And then you see the other 6 domains that are in between. So each domain spanned from anywhere from 10 to 15 points out of 100. And so our third step then was question creation and importance rating. So having then achieved consensus on the final set of the domains and their weighting, we embarked on developing assessment questions among our assessment work group, and then we came to consensus on what those questions should be. We then brought those assessment questions back to the steering committee, who then anonymously rated the importance of each of the questions from one of the following options. Was it critically important to assessing readiness? Was it moderately important to assessing readiness, or should it not be scored at all? And so the questions that received a greater than 50% do not score were assigned a 0-point value in the assessment, and questions that got 50% votes as moderately important or critically important were then assigned a relative point value, so that the total point value in that domain for all the questions in that domain would add up to that domain weight that I showed you on that last slide. And so the final value of each question was then normalized based on the total number of questions per domain. And as I mentioned, then that would then yield a 100-point maximum if an EMS agency responded in the affirmative to having every single thing that was asked in the assessment. So our fourth step was then the electronic build and pilot testing before we did the national rollout. So the Emergency Medical Services for Children Data Center conducted the electronic build of the assessment in a manner to minimize cognitive load and ensure high quality data acquisition, promote respondent understanding, and increase response rates. And so to validate the PPRP assessment items and the response options, we piloted the assessment among EMS agencies from a variety of geographic locations and demographic types, with a mix of fire-based, third service, or other models, a mix of paid and volunteer services, and a mix based on pediatric call volume. We also conducted semi-structured interviews with 15 agencies from 11 different states after they had completed the assessment. And the results from those interviews led to some minor reordering of questions, and some revision of certain questions. In addition, we did a second round of cognitive interviews focused on navigation of the actual assessment from the electronic build, which led to some minor modifications as well in the overall structure of the platform of how the assessment looked online electronically. And so overall, the time needed to complete the online assessment ranged from 30 to 45 minutes. It was easy to answer and straightforward based on the feedback that we received from those who completed it. People were able to complete it for the most part in one session, and it was easy to return to the session if they decided that they needed to go away from it to gather some information and come back. Most use a computer to complete it. It was also able to be completed by all over the phone. And for the most part, people felt that the information would be valuable for future quality improvement efforts. And so our fifth step then, it was field testing. And so the assessment was conducted in 2 periods. So from January to March of 2024, we invited 2 states and 1 territory to do the assessment. And then after that, our second step was we then did a more national rollout from May to July 2024 for every state and territory in the United States. We then, in order to do so, we contacted each agency using the EMSC program centralized national repository for pre-hospital agency contact information, which is updated by each state's EMSC program staff. And the online survey inserts state-specific terminology and response options and has automatic branching based on respondent answers. And then we collected the data. And the data that we collected included agency demographics as well as information on each of those 8 domains that I mentioned, including the presence of a pediatric emergency care coordinator. So I will go ahead and turn it over to my colleague, Dr. Adelgase, who will share the results with you.
Thank you so much, Manish. I appreciate people's time and attention, and also putting up with my slide advancement, which hasn't been as on key as I was hoping. But I'm Kathleen Adelgase, and I am one of the co-leads of the PPRP steering committee that Manish described earlier in the presentation. And I'm going to take the next few slides to go over the results. So this survey was sent, or the assessment, we had over 15,000 US EMS agencies that were invited to participate. And we were really impressed that 7,039 took us up on the offer and participated. About 50 of these participants were actually excluded because they did not respond to 911, leaving us a total of 6,989 EMS agencies that over a 3-month period basically completed the assessment. About 1/3 of them were BLS only agencies, a total of 1,985, and the remaining were either intermediate or advanced life support agencies, a total of 5,004 agencies. And you can see below, 71% of the agencies responding and completing the assessment were transporting agencies, and then about 40% reported having a pediatric emergency care coordinator. Overall, the readiness score achieved by all respondents median was 66, which we were quite surprised by and actually quite happy with. One thing I can say, as this assessment was being rolled out, we would get some emails about having an agency complete the assessment and being maybe upset that their score wasn't necessarily higher. However, one of the things that we wanted to reiterate, and we're so grateful for the number of people who are attending this webinar and hearing about this, is that this is the first time this assessment has ever been done. And we didn't feel like there was any actual bad score. We wanted to really understand how are EMS agencies doing, and then the ability to score this is one, allows us to get a global sense and do benchmarking comparisons, but it also allows us to understand the importance of a score later when we start to use this data to look at outcomes. So we also can use the information collected here to get an overall sense of how well our agency's doing overall. And so what are we doing well? Well, first, in the patient and medication safety area, which actually had a total of 14 points assigned to it in the weighting that Dr. Shaw just described, we're actually doing really well. 81% of respondents reported having a length-based tape or a volume-based guide, and about 77% of agencies report having some way to secure children in the back of an ambulance during transport. Additionally, almost universally, agencies got a score of 12 out of 12 with regards to equipment and supplies. 83% report having pretty much all of the recommended equipment, and the recommended equipment that we're referring to here is the recommended equipment list that has been jointly published by the National Association of EMS Physicians, along with the American College of Surgeons and some other national organizations focused on emergency care. So there's been pediatric equipment in that list for the last 10 years, and the EMS for Children program has really been working hard to kind of advocate for this. So we're pretty excited to see that the large majority of agencies actually have all the recommended equipment. And then again, if, not surprising, the equipment is inspected every 2 years. This is probably because of requirements in state, county, and local agencies that license ambulances. And then finally, with regards to policies and procedures, this was also a higher rated domain in terms of total points. In the median score was 11.5 out of 13, where we were really surprised to find that almost 3/4 of agencies responding have access to a pediatric physician for, basically reviewing their policies and procedures. And again, 3/4 of agencies do regular updates to their pediatric protocols. So what you can see here is there's real attention in high scoring domains around having equipment, having some medication safety guidance, and then also having policies and procedures that do address children. But what needs improvement? Not surprising, family-centered care is kind of an area where there's still some gaps to be addressed. And about 70% of agencies do report having a policy that allow for parental presence in transport in the back of an ambulance, but only 41% of agencies have some policy around parental presence during resuscitation. Within this domain, what we call interactions with systems of care, which is really where is EMS in the continuum of emergency care through disaster preparedness, MCIs, and then interacting across the public health sphere and with hospitals. There's still some gaps there as well. Only about 70% of agencies report doing any kind of data exchange with hospitals, which I think is really critical to understanding what pre-hospital interventions in the field have impact on children downstream. Only about half of agencies actually have some form of a pediatric disaster triage tool. And then only 1/3 of agencies actually have pediatric antidotes in their medication armamentarium. And then this is one area that we're really going to be working hard on over the next several years, and that's in the quality and process improvement arena. On average, EMS agencies only got 6 points out of 12, about 50% of the total points, and about 60% report doing regular pediatric encounter review, and only 40% have pediatric quality measures. And I think the thing that we're really wanting to kind of reiterate here is that the whole point of doing the assessment in the first place was to help to identify these areas. Where are there gaps? Where do we need to provide EMS agencies tools and resources to improve care for children? And then education and competencies. This is the domain with the highest score in the 100-point assessment. And the EMS for Children program has actually annually assessed this for over a decade, since 2017. And it includes both psychomotor, cognitive, and behavioral skill assessment. And we haven't seen much improvement overall in the last basically 10 years that we've been asking some questions around skills training for EMS with pediatric equipment. About the median number of points is 10 out of 15, about 2/3 of the total points, but we found that only 50% of agencies actually do pediatric skills competency assessments twice a year. So this is an area that we do feel might be able to make some gains. And so, as I mentioned, how are we going to address these gaps in pediatric readiness? We really do need to kind of provide both tools, resources, and supports to EMS agencies. But most important, we do feel that the role of a pediatric champion or the role of a pediatric emergency care coordinator is key to this, to being able to drive change for EMS agencies in their overall pediatric readiness. And how do we know this? What can I tell you about PECs and how important they are? Well, first of all, what do PECs do? We've been annually assessing, does your EMS agency have a PEC? And if so, what do they do? And the recommendations around what they should be doing and what we're finding what they do are really from guidance that we got about 2 decades ago through the Institute of Medicine that advocated for pediatric emergency care coordinators in EMS systems. So first, the goal is that they're ensuring that pediatric perspective in EMS protocols. Many PECs are not necessarily EMS medical directors, and so they don't write protocols, but they can ask questions of, well, where's the kid in this protocol on seizure management? Where's the kid in this protocol on sepsis recognition? They also help their agency follow pediatric clinical practice guidelines, and then they ensure the availability of medications, equipment, and supplies. And as you can see, we're really doing well in that equipment and supplies area. We're doing really well in having length-based tapes and other things to support safe medication dosing. PECs also promote pediatric education. We found that the large majority of PECs, this is their primary role, is in helping with pediatric education at their agency. Some of them participate in injury prevention. They also support policies and procedures around family-centered care, and maybe even some of them actually participate in research efforts. And then finally, they often are really front and center in overseeing pediatric process improvement, supporting some disaster planning, and liaising with the emergency department PAC. This last bar really being that interaction and systems of care kind of domain where there's still some work to do. And when we looked at the assessment, we compared EMS agencies that had a PEC to those that did not have a PEC. And we found out that if an EMS agency, you were one of the 40% of respondents that reported having a PEC, you were likely to have higher scores in all domains. And in fact, you were likely to have a perfect domain score for virtually all domains, with the biggest impact in those areas of that were for improvement. 1, education and competencies. 2, interaction with systems of care. And 3, in the quality and process improvement arena. So having a PEC is going to be the biggest driver of pediatric readiness in the areas that we feel like are critically important to start to drive and improve care for children. So the bottom line is that appointing a PEC is really the single most important step that your EMS agency can do to be ready. And so I'm going to cover some resources to help support your EMS agency. And if you have a smartphone out with a camera, we do have some QR codes ahead for you to kind of start to log certain websites into your resources. So do you need quality improvement help? Well, the several members from the PPRP steering committee came together with other national stakeholders and created a set of quality measures in collaboration with the National EMS Information System. They have a dashboard, and you can find 7 of the measures built on the dashboard, but you can find a list of all of them in a publication that's coming out soon by Dr. Caleb Ward. These include 5 around airway management, 4 with regards to trauma, 3 with regards to pain control, 3 with regards to respiratory distress, 2 measures with regards to cardiac arrest, and then some other measures such as anaphylaxis, trauma destination, getting vital signs, etc. And you can't know where you need to go and how to improve unless you actually know where you are. And so these quality measures actually allow, if you don't have a QI program for pediatrics, this can give you a set of measures that you can start to look at. If you need help with disaster preparedness, there's some information available for you right now. There is a pediatric disaster checklist for hospitals, one as a QI initiative to also get some materials. And then we're currently working on a disaster preparedness checklist for EMS agencies with the hope that the first draft of this will be available on the EIIC website in the summer. We have been kind of using that disaster checklist for hospitals and mirroring certain domains and certain areas to help EMS agencies be prepared for pediatric disasters as well. What are the things that they should be incorporating in their training, in their drills? What are the policies and procedures? What are the legal implications around mutual aid and things like that? The other thing is that there are several disaster preparedness networks where there's some pre-hospital engagement. The first is the Pediatric Pandemic Network that actually has a pre-hospital domain. There's Region 4 for kids. There is the Gulf 7 Pediatric Disaster Network, and then there's also RAPM. And these are across the country that they're centered in both hospitals and public health departments and healthcare coalitions to really start to create a lot of resources and tools to help with disaster preparedness. Oops. The other thing I wanted to advocate for is the Pediatric Emergency or Education and Advocacy Kits, or PEAKs as we call them. So feel free to go to the EIC website at that QR code you see on the slide. We've to date have a total of 8 peaks available right now. All of these peaks have resources for EMS agencies. The status epilepticus peak, as an example, is something that Dr. Manish Shah has helped develop given his work in seizure management. There's one on suicide, one on pain, one on procedural sedation, which isn't super EMS specific, one on sepsis, agitation, child abuse, which has some new infographics available to look at, to give some guidance on how to identify cutaneous injury, both burns and bruises in children, and then also one on multi-system trauma. These peaks have resources, infographics, materials, policies, as well as some bottom line recommendations and even some educational modules. And then if you missed the QR code earlier in the presentation from Dr. Shah, check out our toolkit. There are over 200 resources across those 7 domains. It's multimedia in nature. There are curricula, there are just-in-time videos, there are policies and templates. And again, there are some QI resources there. So we really work hard on this, maintaining this toolkit. Every domain gets reviewed at least once a year, if not twice a year, to verify the links are working. And in fact, if you have a resource that you use in your own EMS agency that you feel would benefit this toolkit, there's also an opportunity to kind of click a button and say, hey, I've got a resource that I'd be happy to share, and we can import it into the toolkit if it's open access and something that you feel would be beneficial. So, one question comes up, since about 50% of or maybe 55% of agencies across the country actually didn't do the assessment. You can find on the QR code the EMS Peds Ready website, and that actually has a paper copy of the assessment that you can download. But we're really excited to say that the assessment will be coming in the late spring and will be open and available for anyone to do it. If you've even already done it and you've been doing some pediatric readiness work in your agency, you'll be able to take it again and see if your score is improved. If you haven't done it, I really recommend that you check it out and get a sense of where are your gaps with that gap report that gets generated when you complete the assessment. And then what are our next steps? Our biggest goal is to really study the impact of pediatric readiness in pre-hospital care. We want to see, how do children actually do better if among agencies that have worked on their pediatric readiness, and what do scores mean? What we know in our hospital world is that hospitals with high pediatric readiness have dramatic reductions in mortality, both critically ill children and children with medical and trauma complaints. And when I say dramatic, I mean a 75% reduction in mortality. And it is hard to find any other medical treatment or intervention that has that dramatic impact on overall health. We also have the new resources initiatives that I mentioned. We have a series of PEC learning modules that we're creating for EMS PEC so they can learn more about being a PEC. It's an intimidating thing to feel that they're taking on this role for an EMS agency, because most PECs are not necessarily pediatric experts. And we also have that disaster roadmap coming along. And then we have our quality improvement collaboratives that will be starting in the next year. So we'll keep you guys all abreasted through the NEMT as a partner to inform you of when those opportunities are available. I do want to speak to the impact of EMS readiness recognition programs. These are voluntary programs for statewide EMS recognition as being pediatric ready. And many states actually already have these programs, and they have pediatric readiness standards, and they really get this recognition when they've demonstrated a true commitment to pediatric care. We're hoping that the Pediatric Readiness Project and the assessment can help states who are looking to start these programs use some of these metrics as a way to guide what their criteria might be. Currently, you can see across the country, about 20 states actually have readiness recognition programs, with Florida, Delaware, and New Jersey being some of the newest programs to come online. And what we've heard from our state partnership programs, that those agencies that have gone through the process to be recognized as pediatric ready have just felt like it's been an invaluable exercise and process for them. They do feel like they're really contributing to the care of their entire community when they can care well for their children. And what is an example of pediatric readiness? And it really does mirror many of the items that we assessed in the assessment. And you can see that the pediatric emergency care coordinator is kind of central to ensuring all these things happen. So as an example, these are the Texas requirements. So that they participate in the annual EMS surveys, that they submit NEMSIS compliant data, that they do ongoing pediatric education, including testing and psychomotor, behavioral, and cognitive skills, that they have tools to reduce medication errors, other things such as safe transport, destination, pediatric QI, community outreach are also included in some of their criteria. And if you want to learn more about pediatric readiness, you want to get involved, you want to understand what does it mean to be a PEC, I'd really encourage you to contact your state EMS for Children program manager. This QR code sends you to the EIAC grants database, and you can click on your state, and then you can find your the contact name, number, and contact information for your program manager. All 57 states and territories do have one. We know from the chat the number of people that are international. So we would love to share more about pediatric readiness with you if this is an area in your country that you're really kind of focus on. What I can tell you right now is that the pediatric readiness assessment at the EMS Peds Ready website is actually available both in English and in Spanish, but not necessarily translated into other languages. Dr. Kate Remick will be at the International Conference on Pediatric Emergency Medicine in Hamburg, Germany this June to talk about readiness. And she is a key member of our PPRP steering committee. So if you are attending that conference, find her and talk with her more about how we can bring pre-hospital readiness to your country. And so I'll finish with, really our aspirational goal. The EMS Agenda 2050, which was published a few years ago, really speaks to a people-centered EMS system that's prepared to reliably provide the right care at the right time for the right patient through planning, education, leadership, and communication to ensure that our entire nation, particularly our most vulnerable, our children, are protected. And really, again, want to thank all of those members of our PPRP steering committee. I mean, as you can see here, all of these organizations have dedicated time, personnel, attention, feedback, and other things to kind of really making this work. And I'd also want to give a shout out to those 57 EMSC state partnership program managers and the data center, where we would not have been able to get such a phenomenal response rate and have a snapshot of what pediatric readiness in our country does look like right now. So thank you to everyone. And thank you all for caring about pediatric readiness and for hearing about the results of this assessment. That's all I've got.
Thank you so much, Dr. Adelgaze and Dr. Shaw, for this information-packed webinar. Wow. Just a reminder to everyone that a copy of this slide deck is available as a PDF by clicking on the resources button. We do have time for some questions. I really appreciate that Dr. Shaw and Dr. Alter have been trying to answer the questions in real time because sometimes they get lost in the chat, both the question and the response, as well as in the Q&A. I just want to circle back on a few that have already been answered. So one that I think if you can just address to level set our understanding, what is meant by family integrated care and education?
Family-centered care?
Yes.
Oh, okay. Manish, did you want to take that, or did you want me to answer that?
Sure, I can answer it. So family-centered care addresses several things. So if you look at how we worded things in the joint policy statement, we touched on several aspects, such as the ability for parents or caregivers to ride along with their child during transport, for them to have the ability to see the resuscitation and not be removed from physical proximity of their child when that's occurring. The ability to have language services available for interpretation for those who have a language that they prefer other than English in communication. It also includes narrating key actions. So for example, like if EMS clinician is about to do a procedure on a child, to preemptively communicate that to the caregiver so they know what to expect as the care is being delivered, to do so in a culturally competent manner. So these are several things that I elaborate on that are in the joint policy statement and in the technical report that Dr. Owusu-Ansah published as well. There's further elaboration on that. And so there are specific questions about some of those aspects in the assessment itself.
Great, thank you so much. Dr. Shaw, I noticed that you addressed a question in the Q&A about pediatric equipment costs and the fact that that equipment is seldom used. Can you speak to that a little bit?
Sure. Yeah, there was a question in the chat or the Q&A about for EMS agencies that seldom use certain pieces of equipment because they don't see a lot of children, how that's handled. And so the assessment itself didn't address cost and usage. We do know that from prior assessments that the EMSC program has done, that most of the EMS agencies have most of the recommended equipment that's in the recommended ambulance equipment list. However, I did comment that in my own work in EMS, especially when I've interfaced with agencies in rural areas, that some creative ways that agencies, especially those that are on a tight budget, have addressed this challenge of purchasing equipment and then having it expire because of infrequent use is to go into a cooperative agreement with other agencies in their region. And sometimes that's feasible to do, where they can purchase equipment in bulk and then distribute it among agencies in a region so that they're not spending large amounts of money for using one item out of something that might come in a pack of 100, as an example, but still allows them to have that necessary equipment when care needs to be delivered.
The other thing I'll point out is one of the things that we have been working on is creation of a grants database of states that have maybe certain programs or rural health initiatives or other places where people can get pediatric equipment to help with their EMS agency. As an example, in Colorado, where I clinically work, there has been incentives for our annual grants program that if you are going to use some of the money to purchase pediatric equipment, you get a higher match from the state. And so there are certain things such as that are available. And we have been working a little bit on the a little bit of a website or a information for people to kind of access and take a look at that right now. I was going to let me ask you, Nancy, there are a couple of open questions. I didn't know if you wanted us to try to address those at all.
That would be fabulous. Thank you.
So Bruce Brador Quant asks about, with the strengthening of readiness for pediatric emergencies and non-emergencies and services and treatments becoming more prominent, with you and your teams and associations initiatives, will you be incorporating AFN considerations, utilizing CMS-IT and ABA therapy materials that may prove beneficial? Bruce, we have actually, the issue around CMS-IT just came up in our work on the pediatric readiness checklist for disasters for EMS. And so there will be some recommendations and some guidance coming on that. The other thing I'll mention is that we are now 5 years out, 6 years out from the publication of that joint policy statement that Dr. Shah described, and it's currently undergoing revision. And I think both with the data from the PPRP assessment, as well as more recent publications on pediatric readiness, we will be looking at things that we'll be adding in that may be beneficial to overall pediatric readiness. And then let me see, there's a couple of others. Thank you, Chelsea, for the information about Dayton Hospital's website. We will get that fixed. And Manish, you're typing an answer on access to telemedicine in motion. I don't believe that was one of the questions on the assessment, but that's an example of things that we may be finding important to add in.
There was also a question Dr. Shah just addressed about whether there's a toolkit available for pediatric drowning prevention and resuscitation.
Yeah, so as far as I'm aware with the toolkit, we didn't have something, unless you're aware, Dr. Adelgeist, but I referred people to the American Academy of Pediatrics website, where they do have a comprehensive drowning prevention toolkit online.
Thank you for that. And I do, we do talk about PECs being involved in injury prevention. And there are some questions on the assessment around injury prevention. And I don't believe that's in that interactions with systems of care component. And since we know there are gaps there, I think that we just need to do a deeper dive into the data and what that looks like, and then start to identify where is there a benefit and need for injury prevention work. I will also point out that many EMS for Children program managers, the reason why every state has a program is because they get grant funding from the federal government, and they can use some of those dollars to do local things. So in Florida, where there's a lot of pools and people on coasts where there's a risk of drowning, versus some other communities where maybe there'll be things to address tornado preparedness and things like that. So the goal is that EMS for Children programs are able to kind of use some of their resources to tackle local things that impact the patients and the children in their state. And so I would advocate that if you feel like this would be beneficial, to reach out to your state partnership program manager and speak with them about some of those extra toolkits that might that you think would be helpful.
This is so much amazing information. Wondering, for anyone who's maybe excited but overwhelmed, if each of you could identify what would be your one major takeaway for clinicians attending this webinar, or what would be the first next step for them to really move pediatric readiness forward for them?
Well, as an agency, I would say identify a PEC. As an interested member of the webinar community who cares about pediatric readiness, volunteer to be a PEC and reach out to us for more guidance on that, like the PEC modules that we're developing and other things, because I do think that this all starts with a person in the agency who identifies this is a need for their agency and tackles one problem at a time. The other thing I would say is do the assessment if you haven't done it, or look at your assessment if you have, and see where is there an area that you want to start to make some change. As an example, since quality improvement really is the foundation by which you can make change in an organization, that would be another good place. Manish, I don't know if you have other thoughts or recommendations.
Oh, sorry, I was looking at the chat, so I got a little distracted, I'll admit. I saw some very pertinent questions that I wanted to address about PECs. So I saw some people ask questions about like what states have PECs, how many PECs can you or should you have? So I want to elaborate a little bit about that. So a PEC can be an individual, it can be a committee, it could be a shared resource that is spread among many agencies, or it could be one person based in a single EMS agency. So the way that we assessed it in the assessment, it allows for all of those options to get credit for calling someone a PEC. And We don't specify what type of training that person needs to have. A PEC could be a paramedic, it could be a nurse, it could be a physician, it could be. It's really just a pediatric specific champion for that EMS agency, and there are PECs in I think now every state. Correct me if I'm wrong, Dr. Adelgase and Rachel. But I know that there are ongoing efforts through collaboratives that the EMSC Innovation Improvement Center has had to increase the number of PECs over time as well.
We did have a PEC workforce development collaborative that we conducted a couple of years ago, and that was really globally for both hospital and pre-hospital PECs. What I'll say is that the work that we're doing now with the pre-hospital pediatric readiness project and the finding about how important a PEC is for an EMS agency is going to be driving some future work in the next couple of years around creating more collaboratives that really engage directly with the EMS agency PECs and work also on recruiting more PECs to help with giving them the tools, resources, and support. Currently on the EIC website, there are a lot of resources for PECs. There was a PEC learning collaborative among 9 states several years ago, and there were some real lessons learned there, and those resources are available on the website as well. You can also always reach out to us at the EIC for additional guidance, questions, and support. We have an email address, and I don't know if Rachel or Joanna can put that in the chat for everyone to kind of just ask questions about where to begin.
And just a friendly reminder that if you are able to download the PDF of this slide deck, Dr. Adelgase and Dr. Shaw both included their personal email addresses in the slides. NAMT would like to take this moment to thank today's sponsor, FirstNet, built with AT&T. We thank you for your support and for helping to advance the EMS profession.